Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. Today, I have the great pleasure of having back on the podcast Vivek Podder, who's at Mount Sinai Medical Center, Division of Gynecologic Oncology, Miami Beach, Florida, and Brian Slomovitz, also at Mount Sinai Medical Center, Division of Gynecologic Oncology in Miami Beach, Florida. Today, we're talking about a recently published article, a very hot topic, GLP-1s. The title is Repositioning GLP-1 Receptor Agonists in Endometrial Cancer, Molecular Rationale, Preclinical Insights, and Translational Opportunities. This was very recently published in the Clinical Cancer Research, and we want to welcome both Vivek and Brian back to the podcast. Thank you so much, of course, obviously, for accepting our invitation, for your our opportunity to speak about this very important topic.
Yeah. Thank you so much, Pedro. It's always great to be here. Again, I'm humbled and honored to be here. Just the two highlights as we go through. One, for a change, we're talking about prevention, and as you taught me, you taught me the best way to treat cancer is to prevent cancer. So, I'm really excited that we're talking about that with a new novel way, right? We'll talk about that. And secondly, I'll give you a shout out. You've done such a great job. You turned that journal around, which we appreciate. But the fact that you're actually highlighting an article that's in another journal isn't something that many leaders would do. And I think, and I appreciate that tremendously, because it is an important topic, and I'm sure there'll be many more related topics in your journal. But thank you for that, Vivek.
Brian, thank you so much for those words, and of course, obviously, I'm extremely proud of you and having taken part in your training many years ago, of course, and you have done so much for the field of gynecologic oncology, and particularly also for women with endometrial cancer. So always learn so much from speaking with you, and I look forward to this discussion. And Vivek, again, also thank you for your time and accepting our invitation.
As
Thank
you
you.
know, Vivek's our research fellow here, and Vivek, want to introduce yourself. But it's great to as you taught me, training the next generation is super important, Vivek.
Yeah. Thank you, Dr. Ramirez, for inviting us on this podcast again. And I am a research fellow. My name is Vivek Podder, and I am a research fellow working at the Division of Gynecologic Oncology at Mount Sinai Medical Center with Dr. Brian Slomovitz. And I take pride in working with Dr. Slomovitz in many different projects and many impactful projects. And this is one of the paper in that bucket. So I'm so happy to discuss about our paper in this podcast. Thank you again
Excellent.
for inviting us. Yeah.
Excellent. So let's get started. And we'll go to the first question to you, Vivek. Can you explain the biological link between obesity-related metabolic dysfunction and the rising incidence of endometrial cancer?
Yeah, sure. That is a very interesting thing. So there is a global rise in endometrial cancer that is actually mirroring the increasing rates of obesity and metabolic syndrome all across the globe. But there is a biological and there is also epidemiological relation. So biologically, what obesity does is obesity creates a pro-tumor environment in three major ways. It means it creates an environment where the tumor can thrive, grow, and proliferate and progress. So first, the excess adipose tissue in the obesity increases the estrogen production and also reduces the sex hormone binding globulin. That leads to chronic unopposed estrogen stimulation of the endometrium. Second thing, there is elevated level of insulin, which actually activates the mTOR pathway, which is one of the most frequently dysregulated pathways in the particularly type 1 endometrial cancer, that also promotes proliferation and survival. And thirdly, and importantly, chronic low-grade inflammation, which actually increases the levels of cytokines and adipokines, further reinforces this tumor-promoting signaling. So this is biological relation. There are many other pathways, but apart from that, epidemiological, there is a very strong association, which we have already we have cited in our paper, which is like for every 5 kilogram per square meter increase in BMI, there is an increase of endometrial cancer risk by 50%. So endometrial cancer in many patients fundamentally is a hormonally and metabolically driven disease, which also makes our paper more relevant in this current time of unmet need.
Yeah, spot on, Vivek. The only thing I'll add to that, one of the first slides I put in my endometrial cancer talks is a study back, I think it's 2002, from Cali and colleagues, when they looked at all obesity-driven cancers, and the relative risk for developing cancer of all the cancers with obesity is highest for endometrial cancer. So of all the cancers you could develop if you're obese, for women, obviously, endometrial cancer is the one most likely the highest relative risk. So, it's a problem. It's a problem we've known for a while, and it's a problem that we're hoping to begin to solve with this that we'll talk about.
Yeah, and it's so fitting, particularly for this particular target. So I'll turn back to Vivek and ask, does the GLP-1 receptor exist naturally in the endometrium? And how does it express, how does it change in malignant tissue compared to benign tissue?
Yeah, that's a very relevant question. So yes, the GLP-1 receptor is naturally present in both in the endometrium and is detected in both normal and malignant conditions. But in benign endometrium, it's localized mainly to glandular epithelial cells. But when you compare with the malignant tissue, the key point is not whether GLP-1 receptor is simply present or absent, but the expression appears heterogeneous. How? Like we have cited some studies in immunohistochemical studies and transcriptomic studies. We found that GLP-1 receptor is expressed in both benign and malignant samples. For example, in one of the studies, we found that there is a high expression of this receptor in almost 90.8% of the low-grade endometrial cancers, as compared to 76.4% in high-grade or non-endometrial tumors. So we also emphasize that whether GLP-1 receptor expression falls with, it reduces with malignant transformation or it instead persists primarily in endometrial cancers is not settled yet. So the most accurate way to summarize would be like GLP-1 receptor is a native endometrial receptor. It remains detectable in cancer, but the levels and patterns vary by grade and histology. So that's why in future trials, it is very important that we also do a receptor profiling and use a standardized validated assay in those patients, so we know consistently across the consistent how the receptor is expressed all across different spectra of the cancers.
So Vivek, follow up to that is how do GLP-1 receptor agonists balance direct anti-tumor signaling with the indirect benefits of like weight loss and improve insulin sensitivity?
Yeah, that's a really a central question in this area, like whether it's solely because of metabolic benefits or there's a direct tumor benefits or both. The answer from our review, we found that it's likely both. So first of all, on the indirect side, the GLP-1 receptor agonist improves as we have already talked about how it affects the endometrial cancer incidence. Similarly, GLP-1 receptor agonist reverses all those things. Like it improves the insulin sensitivity, it reduces the circulating insulin and the insulin growth factor signaling. And apart from that, it also reduces weight loss, reduces weight and also improves the systemic inflammation. So all of these factors, which you already talked about, was promoting endometrial cancers. So by giving a GLP-1 receptor agonist indirectly, it is actually reducing the endometrial proliferation and also the progression. But there is also, we found that there are evidence for direct tumor intrinsic factors. It means it intrinsically affects the tumor cells and it reduces the cancer proliferation indirectly. How? The endometrial cancer cells express the GLP-1 receptor. So when it is activated, it stimulates the cyclic AMP and phosphokinase A signaling mechanism and also activates AMPK pathway, which leads to mTOR separation. And eventually it leads to cell cycle arrest and increase the apoptosis. In even in some xenograft models, the tumor growth inhibition even occurred. This also gives an evidence that why this GLP-1 agonist has a direct effect on the cancer cells. In some of the xenograft models, we found that tumor growth inhibition occurred even in the absence of changes in weight or insulin levels. It means all those factors which were actually indirectly affecting the cancer growth is even uh, taking place even without those changes. It means it has some receptor mediated effects independent of the metabolic changes. So rather than thinking of it as one versus the other, I think it's probably dual mechanisms which is helping these patients most likely which we'll know in the future trials.
Excellent. So, Vivek, I'll go to our next question is how do GLP-1 receptor agonists help sensitize endometrial cancer cells to progestin therapy, and which is the current standard for fertility sparing care?
Yeah, thank you for that question. This is one of the most exciting translational aspect of the paper, where we had an opportunity to talk about some of the translational evidence for this GLP-1 in endometrial cancer. So fertility sparing therapy in endometrial cancer relies on progestins, and resistance is a major limitation, and much of the resistance is driven by either loss or dysfunction of the progestin receptor. So in preclinical studies, we found that GLP-1 receptor agonist activation activate the receptor, and it can restore or enhance the progesterone receptor signal. How it happens? Mechanistically, GLP-1 receptor increase the expression of both progesterone receptor A and B isoforms, and also it promotes their nuclear localization. So how it happens? This appears to occur through cyclic AMP, PK, and Krebs signaling pathway. This is one pathway that improves the expression of PRA and PRB isoforms. There is another aspect of this, which is actually improving the functionality or stability of the receptors, which is it increases the PGR-MC1 and 2 expression, which is progesterone receptor membrane component 1 and 2. So which basically stabilize and enhance the progesterone receptor function. As you have already talked about, that in the basic problem with the resistance is the loss or dysfunction of the progesterone receptor. So GLP-1 receptor through these two independent pathways and independent but interlinked pathways, they actually first increase the progesterone receptor expression, and also it improves the functionality of the receptor. So when GLP-1 receptors are actually combined with progestins in those cell models, it was found that the anti-tumor effect is greater as compared to when the progestin is given alone. So particularly when the activity is low. So the concept is not that GLP-1 receptors are going to replace the hormonal therapy, but that may help to resensitize the tumor cells by restoring those resistance mechanisms, which was actually reducing the impact of progestin. So in this way, it is actually improving the progestin sense. It is sensitizing the tumor cells to act more responsibly to the progestins. So I think it has more impact on the prevention of the cancers, and also as a complementation to the progestin therapies.
Excellent. So I'll turn to Brian now. And Vivek talked about resistance. And this next question, Brian, is what evidence is there that GLP-1 receptor agonists can reverse hormone resistance in patients where traditional progestins have failed?
Thanks for that, Pedro. And the key to a lot of treatments, we know that hormonal therapies work, not only endometrial cancer, but breast cancer and even some ovarian cancers. That's the key to help overcome the resistance in those that don't work. Previous studies have shown mTOR inhibitors, CDK4/6 inhibitors, other biomarker-driven pathways can in fact help overcome that resistance. And based on what Vivek just described, having these GLP-1 receptors on tumor cells, we feel that they may in fact work in this sort of biomarker-driven pathway of affecting the intracytoplasmic proteins that are there. A lot of this is preclinical, right? A lot of this paper, truthfully, was hypothesis generating, a review of what's out there and the steps to move forward. We do know that the GLP-1, these agents, the GLP-1 RAs, they can restore progesterone receptor signaling. They can do this by increasing the progesterone, both the A and B expression and its nuclear localization. This could further support the increase, the restoration of progesterone function. Really, when we're combining these GLPs with progestins, we're looking for a synergy. We talked about an additive. It may in fact be a synergy of restoring apoptosis and even reducing the viability of the cellular growth, even when there's low PR, because that low PR can be turned into high PR with this biomarker driven pathway, the progestins alone. Clinically, again, we have observational signals that this may work. There was a large study. We called it a large propensity match. It's called the TriNet X analysis, reported saying that adding GLPs to progestins, it was associated with a lower risk of progression to endometrial cancer in patients with benign disease, including those that have the Mirena IUD, okay, the intrauterine device, or systemic therapy. And as we know, the Mirena is really ideal in these situations because it doesn't give us that systemic progestin effect, which is water retention and weight gain. We know that also some other clinical chart reviews have limitations, obviously, and a lot of these findings are just hypothesis generating. Bottom line, there's definitely a biologic rationale for salvage here. It's strong, supporting the insulin resistant, the hormonal resistant models. On a patient level and clinically, we need to further this with a proof of concept type studies. The one optimism here, in all diseases we've evaluated, don't bet against the GLPs. Diabetes, hypertension, cardiac disease, Alzheimer's disease, they work. So having this preclinical rationale, gives us really optimism that it will translate into clinical benefit.
Excellent. So I'll turn back to Vivek. This question from one of our fellows, Anusha Kamath from All India Institute of Medical Sciences in Nagpur, India. And she's asking, your review highlights that GLP-1 receptor agonists are GLP-1 receptors are expressed in both benign and malignant endometrium. How consistent is this expression across histologic subtypes and TCGA molecular classes?
Yeah. Thank you for this interesting question. So I have already answered part of it. So we don't know that GLP-1 receptors are expressed in both benign and malignant endometrium. But the consistency of that expression across the histological subtypes and particularly the TCGA molecular classes are poorly defined. So what the available evidence suggests that GLP-1 receptor expression appears more prevalent in low-grade endometrial cancers, where the expression is more heterogeneous in high-grade and non-endometrioid subtypes. So that already tells us that there may be a subtype level differences. So for the TCGA classes like pole-mutated DMMR, p53 abnormal, and NSMP, we do not have any robust standardized datasets which actually mapped how the GLP-1 receptor expression looks like in these categories. So part of the issue is technical, which is that there is a issue with the antibody validation and the scoring methods, which is actually which vary across the studies, which makes it difficult to cross study, which makes it difficult for to make it comparable across all the studies. So the most accurate answer would be, I would say, the GLP-1 receptor is present in both malign and malignant tissue, and it is mostly is concentrated and more expressed in type 1 disease. But whether it remains, it's a question for it's a translational question, whether the distribution is homogeneous or heterogeneous across all the molecular subtypes with a better validated studies. So yeah, and future trials may be able to be future trials should answer those questions with more accuracy.
Great. And Vivek, I'll stay with you on this question from Australia, Nicole Chris. And she's asking, in preclinical studies, GLP-1 receptor activation seems to inhibit growth in type 1 tumors. that may produce the opposite effect in more aggressive subtypes. Is there observational or retrospective clinical data to suggest that GLP-1 receptor agonist use is associated with cancer progression in type 2 endometrial tumors? And how should these signals inform eligibility, biomarker requirements, and agent selection in future trials?
Yeah, so I will partly answer these questions and partly I will ask Dr. Slomovitz to answer that. So this is a very interesting question in our review, that why the GLP-1 receptor agonist is working on some cancers and it's even giving opposite effect in some other aggressive subtypes. So we do not currently have the clinical observational data that shows that GLP-1 receptor agonist can accelerate progression in more aggressive endometrial cancers. However, we have a preclinical data that raise an important caution. Like in serous-like AN3CA models, exendin-4, which is actually a GLP-1 receptor agonist, increased the proliferation and invasion. So it suggests that the responses which you see in the GLP-1 receptor may be subtype or ligand dependent. So we have to, so these preclinical trials also suggest, I mean, these preclinical findings also suggest that the future trials should also consider the histology, stratification, biomarker, better biomarker development, and also the agent-specific way of looking at the stratification. So we know actually whether it is a class effect or it has some other it is not a class effect also. So, and in terms of the biomarker requirements, eligibility criteria, and the second part of the question, I think Dr. Slomovitz can add more insights to this part.
Yeah, no, thank you for that. Yeah, I think what you're, and that's the question from Alan Matthew, right? As far as the biomarker expression. So before diving into that, remember, endometrial cancer is a heterogeneous disease. So when we say GLP-1s may affect endometrial cancer, it's not going to affect all the cancers in the same way. Just like every other endometrial cancer therapy, some of them more responsive to chemo, some aren't. Some are more responsive to hormonal, some aren't. Immunotherapy, some are more responsive to immunotherapy, some aren't. So we're not saying in these hypothesis generating clinical trials, which are next, we're not saying they're going to have the same response, but that's the important of the looking at the subtypes that are treated and the subsequent translational work associated with them to help better define that population that may in fact have tumor manipulation with the GLP-1s. Regarding biomarkers, again, there's no biomarkers yet. This is going to be, as I was alluding to, it's not only histologic differences in the tumor biology, difference in the metabolic phenotype. Adding GLP-1 receptor antagonists is not ready for, immunohistochemistry is not ready for prime time today, but I suspect in the future, just like ER, just like PR, just like HER2 and alpha folate receptor doing more and more, I suspect the same thing's going to happen with these type of tumors. Obviously, this expression is the best, is in the lead as far as what's going to work, as far as which biomarkers may be of interest. We may put more of a reliability again back onto the progestin receptor status, dividing it into PRA and B. As potentials. We may continue to look at Ki-67. We talked about a proliferation index years ago, how that's important. We may go back to that in some respects. Also, the AMPK activation pathway, mTOR signaling, those pathways may be of importance. Metabolically, weight, visceral adiposity, response to hemoglobin A1C. These are all markers of a systemic inflammation. A lot of cancers are driven by inflammation. GLP-1s may work, as Vivek described, on a molecular level, but the general tense may be that they're anti-inflammatory in nature. So really the idea approach now is just to do these studies. Let's get going on the studies. Let's see what we find and build upon those studies to ask the next generation of questions.
Great. So, Brian, I'll turn to you also for this question. Vincenzo Tarantino from Gemelli Hospital in Rome, and he's asking, your review suggests that GLP-1 receptor activation can suppress tumor growth, yet high GLP-1 receptor expression is linked to poorer survival in some data sets. How should clinicians interpret this paradox?
Yeah, so great question. The easy answer is we still, great question to ask. We still need to learn. We've seen this paradoxical type of effects in all different levels of these preclinical studies that we see. We know that preclinical models show us that activating GLP-1 receptors can in fact suppress growth through these pathways described, AMPK, mTOR, other similar pathways. Transcription data sets suggest a higher GLP-1 receptor expression is in fact associated with a worse survival. But we need to interpret this with, again, hypothesis generating, not as proof. Possible explanations: high GLP-1 expression may simply be a marker of more aggressive tumor context. It may divide the NSMP estrogen receptor positive into two different types, more aggressive and less aggressive. We need to learn more on that. It may reflect this subtype differentiation. Also, mRNA expression doesn't tell us whether the receptor is in fact functional. The RNA needs to turn into the activated proteins in order to have more of a phenotypic change there. Practical takeaway: this paradox really highlights the need for more standardized receptor measurements. It's tough to have a standardized receptor measurements. We still don't have a standardized way of measuring estrogen receptor. So I don't suspect that we'll be able to do that in the near future, but hopefully that'll be a long-term evaluation that we have.
So, Brian, as a follow-up question to that from Lucia Ribeiro in the European Institute of Oncology, she was also asking and interested about molecular classifications. You mentioned a little bit about it just previously, but her question is: the role of molecular subgroups in fertility sparing management is still evolving. How do you see GLP-1 receptor agonists fitting across the molecular classes of endometrial cancer, particularly when comparing NSMP and MMR deficient tumors?
Yeah, no, that's a great question. And the nice thing, and we're moving more and more away from this, is going away from type 1 and type 2 and focusing on these molecular subclassifications. As I alluded to, I think that there's going to be a highest impact in these in the NSMP PMMR, proficient MMR group. Why is that? I'm not saying it's not going to work in the DMMRs, but the current evidence on immunotherapy and DMMR tumors, it's going to be tough to beat. We know the hazard. We've talked about the hazard ratios of GY018 and Ruby in the DMMRs are 0.28, 0.3. So it's going to be tough to beat in those settings.
Mhm.
But in the PMMR NSMPs, we know that there's fewer treatment options. We know that biomarker-driven therapies really have an effect there. We talked about the mTORs and the CDK4/6s with hormonal therapy. So I think this is the area that still represents an unmet need because we can do better. The question included a component of this fertility sparing management. Really cool. So we need to go in that direction. We tend to forget that endometrial cancer can affect younger women as well. It could affect women who are still desiring future childbearing. We're going to be presenting Lucy Gilbert and I, a study that I was involved with, is going to be presenting data at the SGO meeting at giredestrant infertility preservation. Our response rates are good, but they could be better. So maybe combining hormonal therapies with this type of agent as a combination therapy may work. And we talked about the pathways on a technical level. Losing weight can enhance fertility. We know that there's some effect of polycystic ovarian syndrome and obesity is related to infertility. So forget about the molecular mechanisms, which I think are important, but the purely simply as losing weight may help their fertility potential, which is important. Treating the disease, increasing their chance of getting pregnant.
Excellent. So I'll turn to Vivek. Another question from Lucia Rivero. She's asking, in this manuscript, you highlight antibody validation as a critical first step to advance GLP-1 receptor research in endometrial cancer. Could you share which GLP-1 receptor antibodies are currently considered the most robust or validated in this setting?
Yeah, that's a highly technical question and an interesting part of the discussion on GLP-1 receptor. So in our review, we don't endorse any specific best GLP-1 receptor antibody clone because a major problem in this field was the inconsistent antibody selection and validation, and the variability in the scoring methods, and a lack of standardized positive controls. And these issues likely contribute to the conflicting GLP-1 receptor prevalence estimates across different studies. So we need to, I mean, I think it is important to state here that we need a rigorous antibody validation as well as an important prerequisite for reliable use of this marker in the in endometrial cancer.
So I'll turn to back to Brian. And this question, again, also from Vincenzo Tarantino, and he's asking, are GLP-1 drugs more likely to become cancer prevention tools, treatment enhancers, or true anti-cancer drugs in endometrial cancer?
That's a great question, and it's a, in my view, it's an easy answer. Yes, yes, and yes. Right. As far as using them alone, I'm not so sure, but I think, from a prevention perspective, including high-risk patients that want to maintain fertility, want to prevent getting cancer, I think that there's going to be benefit. We talked about the potential with Mirena IUDs, weight loss itself. We talked about the high relative risk of obesity developing endometrial cancer. If we could help patients lose weight, we could, that in itself is chemopreventative. As far as enhancers of treatment, yes, but I'm a little bit skeptical, particularly on those patients. Systemic therapy, our traditional practice has been, even in patients that need to lose weight, maybe not encourage them to lose weight during chemotherapy, because chemotherapy has its own effects of nausea, vomiting, and we don't want to, decrease their reserves at that sense. So I think it would work, but I think we just have to be careful in that setting. Again, standalone, I'm not sure, but the other, the component of this question that's not asked is, how about as a maintenance therapy or as a way after treatment to help prevent it from coming back? And I think there'll be an important role there too. And again, as we learned, again, as you taught me, women with endometrial cancer, for the most part, don't die from their disease. They die from heart disease, diabetes, hypertension. So giving these agents in that setting undoubtedly is going to help them live longer, whether it be from an endometrial cancer, prevent recurrence, or one of these other systemic diseases.
Excellent. So, Brian, this bit of a challenging question from Giuseppe Parisi at Policlinico Gemelli. He's asking, your paper highlights biased molecular pathway signaling across ligands. Clinically, should we stop talking about the GLP-1 receptor agonist as a class in endometrial cancer and instead treat agent choice as the central scientific variable? If you were designing a trial, would you pre-specify which GLP-1 receptor agonists are you choosing?
Yeah, no, I think that's a great question. As you alluded to, it's one of the tougher questions. I think endometrial cancers, we should be cautious about treating them as a single class, right? We don't have strong data on that, but we should be careful. There's definitely bias signaling. Different ligands can drive different downstream processes. These processes is again heterogeneous across the disease. There's the single agonist, the dual agonist like tirzepatide, which can introduce additional biological signaling. It's premature to do that. I actually do think, however, the studies in designing them at first shouldn't be so, it's okay at first to clump them all together. But I think as we get the data to evaluate the data as potential stratifying factors, which may lead to varying response. So as we start off with the trials, it's too early to say which ones we should do or which ones we shouldn't do. But as we learn more and more, again, similar to immunotherapy, right? The first studies on immunotherapy took all comers, right? There was the Starlimab studies, the pembrolizumab studies. They took all comers, and as we learned more, we decided which ones would most benefit, which ones little benefit. So I think it'll be the same thing here in that setting as we move forward.
Great. So just a couple more questions, Brian, for you. I was actually very pleasantly surprised to see that there were actually that many ongoing trials. I believe in your article there's about 6 ongoing trials. My question was, which of these are you most excited about?
Yeah, no, I think that's great. I think we alluded to earlier the combination with progestins, I think, um, probably the most exciting at this point. The really nice thing about these studies is that they're, comparing it to IUD alone. So we could really see the contribution of effect of the GLPs. These aren't just open labeled single arm phase 2 trials. They're really looking for that contribution, which is important. Um, I think that these endpoints moving forward are really going to have to be focusing on disease progression, because overall survival on these, say, advanced cancers that are treated with GLPs is going to improve, but we're just not sure if that's going to be disease specific. It's going to improve for other reasons. So, but the preliminary work with progestins, I mean, I think that's, if anything's going to come into clinical practice sooner, it'll probably relate it to that. And obviously, in these trials, we have to, given the more widespread use of GLPs, take that into consideration. Patients who are already on a GLP when they get diagnosed versus those that are newly started on GLPs as their cancers just diagnosed and progresses.
Yeah. So, Brian, as a last question, as we now usually do, we will ask a question that was formulated by AI when reading your manuscript. And the question is, how confident can we be that the observed reductions in endometrial cancer incidence with GLP-1 receptor agonist progestin combinations are receptor-mediated anti-tumor effects rather than simply just downstream consequences of weight loss, improved insulin sensitivity, and selection bias inherent to retrospective data sets?
Yeah, no, I'm not sure which AI platform you're using, but it's a good AI question. Thank you for that. You could let AI know that. I would appreciate that question. Listen, we're cautiously optimistic. I think it's, to me, it makes sense that the biomarker pathway is going to play more of a role than just the weight loss itself. And we'll see that with overcoming hormonal resistance, hopefully. We'll see that with decreasing expression of the GLP receptor and receptors on the cell by giving treatments with this, hopefully. We're not sure yet. If I were to predict the future, I think it would be. The best really scientific position is that the clinical incidence signal is promising. It's not definitive. And hopefully we'll get more and more preclinical data to further support this as we moving forward, to really better characterize, not subjectively but objectively, differences in the pathway, which will again hopefully confirm to us that it is not just the weight loss, it's other strategies as well.
As anticipated, you handled that question perfectly well. So I think you should be proud of your response to the AI platform. So thank you both again. Really outstanding work, and really, I think certainly this is the beginning of a lot of exciting information about GLP-1 receptor agonists in endometrial cancer. It'll be very, very exciting to see all this data in the next year or two as we evolve potentially towards a new treatment option for patients with endometrial cancer. So, Brian, Vivek, thank you as always for your contributions. Great work, and thank you for accepting our invitation.
Pedro,
Thank you, Dr.
we can't thank you enough. Thanks for supporting us and highlighting this article and spreading the word. I think over the next couple of years, we're going to see a huge amount of research in this area. And, again, a lot of our work is hypothesis generating, chart, reviewing the data that's out there. But I'm looking forward to the next steps and seeing where we go with this.
Thank you, Dr. Ramirez, for having us.